Howdy, Ags. We've made it. This is the long way home. We've just about made it there. So one last lecture. This one's a short one. So this one's on arthritis. And arthritis is a very, very common family of diseases. It's one of the main reasons, I mean, joint pain overall is number one, but one of the main reasons people actually go to see a physician, that folks want to get treatment because of pain, discomfort, and all of the, we're going to talk about three muscular dystrophies, three, check that. Oh, it has been a long semester. Three different types of arthritis. One is going to be osteoarthritis, rheumatoid arthritis, gouty arthritis. Those are the three most common types of arthritis. There's a few additional ones, but we're going to focus on this in the short time that we have left. So hopefully it won't take too long to go over. As I mentioned, arthritis is a family of diseases that affects the articular cartilage and damages it and increases the amount of friction that we find in the joints. So they're debilitating diseases. They affect often the hands, the knees, the feet, etc., but they can also affect the shoulder, just about any joint in the body. Because they involve damage to the articular cartilage, it means that synovial fluid, in a sense, is involved. It's not a cause of the disease, but because it's released by the synovial membrane, it helps to produce lubrication in joints. It's absolutely critical. So the thing about lubrication and reducing friction, it's dependent on basically the fluid and the surface over which it is actually gliding or sliding. So synovial fluid with healthy articular cartilage provides a very smooth movement, articulation as our joints are moving. And it's critical that we think about both, because synovial fluid by itself isn't necessarily super slippery, and the articular cartilage surface by itself isn't super slippery. But when you put the two together, it's kind of the opposite of Velcro, where you put felt and those kind of plastic loops together, and that causes lots of friction. In this case, the synovial fluid and articular cartilage, they're really critical in together in terms of reducing the amount of friction at the joint. So synovial fluid is produced and released by the synovial membrane. Synovial comes from the Greek, comes from syn, meaning with, ovum, meaning egg. So that's where the term comes from. And so it almost has a egg white type consistency. It's a lubricant in our freely movable joints, and it's made mostly of water, hyaluronic acid, and other parts of proteoglycans, as well as glycoproteins or lubricant. Synovial fluid, again, has to work with healthy articular cartilage in order to reduce the amount of friction. The faster joints articulating, interestingly enough, the better it actually works. So that's really a fairly unique property about synovial fluid. There we go. It's temperature dependent, so it's a better lubricant with increased temperature, excuse me. And there's a string test for viscosity, believe it or not. Viscosity helps to dissipate energy. So a viscous fluid actually dissipates energy instead of storing energy. So the opposite of elastic. Click on that. There we go. Here we see the shoulder joint again, and I'm going to point out the articular cartilage surface. If this is nice and smooth, then you have very, very low friction indeed. So arthritis is a family of diseases that affects mechanical function of the articular cartilage. It often is chronic. It takes place over many years and degrades the articular cartilage. Arthritis and chronic joint pain affects 70 million Americans. So together, they're the most common problem. 44 million outpatient visits, 22 billion in medical costs, 82 billion in lost productivity and medical costs. And you can see this is a little dated, but this still holds true today. Arthritis and rheumatism are the major cause of disability. Back and shoulder problems and spine problems are number two. So we're going to start with rheumatoid arthritis. This is a very interesting disease because it's an autoimmune disease where T cells, the body's immune cells, actually start to attack initially the synovial membrane. It's related sort of indirectly to lupus and to Graves' disease. Those are also autoimmune diseases. Graves' disease is a disease of the thyroid gland, and it causes hyperthyroidism. Lupus is another debilitating autoimmune disease. So they're antibodies that trigger T cell invasion. And there's lots of, one of the things we talk about with cytokines and free radicals, prostaglandins, inflammation, those are needed to kind of stimulate remodeling and stimulate repair. But if they go up and stay up chronically, then that leads to chronic disease, whether it's rheumatoid arthritis, hypertension, heart disease, all metabolic disease, type 2 diabetes. All of these are chronic immune diseases in which there's a significant amount of inflammation. So immune cells, meaning attack parts of the body. So in this case, as I mentioned, there's kind of an autoimmune cluster. It's more prevalent in females with Graves' disease, lupus, ankylosing spondylitis, etc. So rheumatoid arthritis starts off as an inflammatory disease and continues that way. Osteoarthritis usually starts mechanically, but then it's accelerated through pro-inflammatory processes. So anyway, cytokines, free radicals, prostaglandins, etc., they just go up and they stay up. I think oxidative stress was first detected in 1972 or 73 by Erwin Fridovich and Joe McCord, who actually helped to discover a major antioxidant enzyme a few years before that. I actually expect them to win a Nobel Prize sometime. It just hasn't happened yet. Unfortunately, Dr. Fridovich actually passed away about 5 or 6 months ago. So it's too bad. But anyway, one of the things that happens as this inflammation continues is that the synovial membrane starts to produce an unusual type of protein that gets kind of gnarled up all the way through the joint capsule. And it's called pannus. It reduces the lubrication, increases stickiness. It's a cluster of usually malformed proteins, vascular tissue. So as I mentioned in the last, our last discussion, vascular tissue, believe it or not, this is one place where we don't want it, on the surface of articular cartilage. Everywhere else, like your heart, your tendons, ligaments, bones, etc., you want it there, but in this case, you actually don't. So here we see actually a femoral head that's normal and one that it has arthritis. This is osteoarthritis, but pannus really becomes a problem in all types of arthritis. Here we see it being produced and it starts to stick to that articular cartilage. So it starts to wear away. In fact, sometimes you can get new bone material being produced inside a joint, like one of your knuckles, for example, or the knee joint. And then some of the bone actually starts to break down. So this is a really significant issue. You can see, wow, that looks, that's rheumatoid arthritis, lots of pannus. It is a problem because then you go from having a nice smooth surface that works with synovial fluid to one that doesn't work very well at all. And at the late stages, the cartilage wears away. You get high friction, even higher friction. bone may be either disrupted or produced because the periosteum has a lot of stem cells and osteoblasts underneath it and can actually produce more bone material that can grow into knuckles in the hand or the knee or other joints in the body. So how do we treat it? Well, anti-inflammatory drugs have been used for a long time, non-steroidal anti-inflammatory drugs. By themselves, they have really a modest effect. They don't slow down the progression of the disease that much, so they provide temporary relief. We've tried more powerful anti-inflammatory drugs. Cortisone is one. Unfortunately, cortisone works like the hormone cortisol, which is a antagonist of insulin. So cortisone is produced by the adrenal cortex, and cortisol, instead of taking up glucose, it produces glucose. And what cortisol does, and what cortisone does also, it sort of persuades the liver to start using amino acids from bone and from skeletal muscle and produces glucose from that through a process called gluconeogenesis. There are powerful immunosuppressants that have been used. Cyclosporin, which is really bad for mitochondria, methotrexate, MTX, has been used. It's contraindicated for pregnancy. There's something we recognize, hydroxychloroquine. Unfortunately, it has bad effects on the heart and increases the QT interval, which increases the risk of bad arrhythmias. So it's been discontinued as far as COVID is concerned, but it's an anti-inflammatory agent, and that's why people were trying it out. Didn't really work. So moving on. So we have new, more focused anti-inflammatory inhibitors, including antibodies. Tumor necrosis factor alpha is a cytokine that's pro-inflammatory. It's involved in the early stages of repair and remodeling. However, like I said, with arthritis, this is a chronic disease where inflammation goes up and stays up. That's not supposed to happen. It's supposed to go up and then come back down and normalize quickly. So some of the drugs you see here are very, very commonly used with rheumatoid arthritis. Infliximab, the AB means it's an antibody. You probably notice this about the medicines that have been coming out the last 5 or 10 years, otherwise known as Remicade. So that's sometimes used. Enbrel is probably the most commonly used anti-arthritic drug, and it's a TNF-alpha inhibitor. It, instead of being an antibody, it actually blocks TNF-alpha from binding to its receptor. So it works through interference, if you will. There's an interleukin-1 blocker, Kineret, which is used somewhat, but not that much. So antibodies, for example, have to be injected, or sometimes people can use a patch for those type of medicines. Because antibodies are peptides, you can't swallow them. It doesn't work because your body will just break it up and you won't have the drugs left. Vioxx used to be used for osteoarthritis and rheumatoid arthritis, but it was taken off the market a long time ago. It's an NSAID, a non-steroidal anti-inflammatory drug. However, it also is not very good for the heart. It prevents new blood vessels from being produced in the heart. That wouldn't be a good thing. There are INOS inhibitors. That's inducible nitric oxide synthase. That's involved in the respiratory burst. That's basically where your immune cells are going to attack a virus or attack a bacteria, or sometimes you're going to digest out damaged tissues in the body. So with rheumatoid arthritis, the synovial membranes attack first, then you have pannus, and then you get fibrotic tissue being produced, and eventually you can even get bone fusion late in rheumatoid arthritis. We hope you never get there. But again, with the type of TNF-alpha inhibitors we use today, that seems to be a really good treatment overall. There is some risk with any type of anti-inflammatory agent, especially immune system suppressant, that you might be susceptible to disease, meaning like a cold, a flu, etc. It could increase the risk. People used Enbrel and methotrexate it worked even better, even though the preference today is to actually use something like Embrel and combine it with exercise. So exercise, believe it or not, is the new therapeutic agent that's used to treat arthritis, but usually in combination with Embrel or another targeted immune suppressant type of drug. So patients with rheumatoid arthritis can usually handle exercise, and it's usually lighter intensity, higher frequency, range of motion type stuff. It may be water aerobics, but resistant training, people can do that as well. So this helps to reduce muscle atrophy. That can help it with arthritis, and because of pain and discomfort, and people aren't using their muscles as much as they would before. So we're going to switch now to osteoarthritis, which is the most common form of joint disease. It's degenerative, it's chronic, it's long-lasting. It usually starts with an injury or wear and tear, overtraining, aging, some combination thereof. There are often abrasions where things start. This reduces the lubrication, increases friction, and then there's secondary inflammation. This secondary inflammation is incredibly important, and in fact, I'm going to underline it. There we go. Because more and more we think the way to deal with osteoarthritis is actually kind of similar to the way we treat rheumatoid arthritis, is to focus on anti-inflammatory and even immune suppressant type therapy. Later on, the cartilage wears away again, and you're left with bone on bone. There's a disruption of the periosteum. You can get degeneration and bone formation. So the joints can basically take on a malformed type configuration, and you can get like valgus and varus in the legs if you have a knee problem that you normally wouldn't get. Non-steroidal anti-inflammatory drugs are often taken. And because things like Embrel, Remicade have worked relatively well with rheumatoid arthritis, we've tried them with osteoarthritis, and they've worked pretty well, especially when you combine them again with exercise. Light intensity, range of motion, have fun with it. Stretching exercises are also important. And then the next phase will be things like hydrogels, whether it's 3D printing or including platelet-rich plasma stem cells and smart hydrogels. These are polymers that can store water. We can actually trigger them to do that and put in all the good stuff, platelet-rich plasma stem cells, hyaluronate, anti-inflammatory drugs. Combine this with exercise, and this may be some of the treatment in the future, especially if you get to the point where articular cartilage is worn away almost completely. So it may be an enhancement or even replacement of the articular cartilage. Finally, we'll get to gout. So you may recognize Henry VIII here. He had gout. Gout sometimes is run in royal families in Spain and Germany and England, France. And as you probably know, many of these folks are actually related to each other. And that may include kings and queens in Denmark and Sweden. So the royal family, yeah, they're kind of unique in a sense. And because they're often cousins, kissing cousins and otherwise, it means that genes that normally wouldn't be expressed because they're recessive genes. Mom and dad both have the recessive gene, and gout is one of those diseases, even though it's not exclusively genetic. The tie there is kind of loose, but it's different than like hemophilia. There's also a disease that turns the blood blue. That's where the term blue bloods comes from, if you didn't know that. It's caused by a recessive gene so that the hemoglobin isn't red when oxygen is bound to it. It's actually blue. If it's green, then I guess you're a Vulcan. But what happens with gout, it's really interesting because it indeed is a metabolic disease problem. So at the tail end of metabolism, uric acid can form. There's an enzyme called xanthine oxidase, which produces it directly. So the problem is that there's so much uric acid being formed, there are crystals on the articular cartilage. It's usually noticed in the big toe first, but it can affect a lot of joints in the body. And so it's one of these things that comes in waves. It kind of comes and goes. Gout really happens when you combine usually a recessive gene with the type of lifestyle, well, you might have had with Henry VIII. Eating a lot of fatty meats, the type of thing that's actually not uncommon in the American diet today that leads to type 2 diabetes, obesity, etc. So the diet seems to be a critical part of that. So metabolism of protein, especially in fat, that breaks down, and xanthine oxidase, this enzyme, is the final stop. It produces uric acid. So when uric acids get really, really high in concentration in the synovial fluid and in the blood, they actually come out of solution. They crystallize, particularly at the joints, and the crystals actually form layers on top of the articular cartilage, starting to wear it away and produce lots of inflammation and pain. So the good news is we have a couple of drugs, allopurinol and oxypurinol, that can actually inhibit it. There's a couple of other drugs that have been used for thousands of years that I think doctors have finally stopped prescribing. There's one called colchicine, for example, which I think is the oldest used drug in the world. It's about 4,500 years old. But allopurinol and oxypurinol are best because they inhibit the enzyme, xanthine oxidase, which produces the uric acid. So it's just like turning off a spigot. So that's probably the best way to deal with it. And in fact, that's actually the end of our last lecture. I told you it's going to be a short one. You guys have been thinking, Dr. Lawless promised a short one. He almost never delivers. He just goes on and on. But yes, this time it's done. The semester is actually over, except for, of course, exams, etc. So if you have any questions regarding exam or content material, ask me. I'm finishing up your exam grading. When I say finish up, it'll take me still a few more days. It looks like so far things look pretty good in terms of those grades. The final is going to be virtually all, if not completely, objective. So it's going to be a lot of multiple choice questions. The good news is they're all going to be short enough so you'll be able to get through them in the time that you've been allotted. So we'll meet at 8 o'clock on Monday for sections 501, 502, 503. That's May 4th, May 5th, Tuesday, 8 o'clock there for sections 504 and 505. So best of luck. Continue to study. Good luck with, and probably at this point, I think you finished your projects. So well done. And thank you for hanging with us in this virtual semester. It's certainly been different. It's been challenging. It's been a lot of work, but I think it's been productive. And it's allowed me to basically kind of beef up some of the slides so they would work better online. If we were together, it's easier for me just to talk through them. But I think it's been a really good thing, even though it's been incredibly busy. So I'm going to wish you guys the best. Again, contact me if you have any issues. This is going to go up immediately, as well as the other lecture that we finished earlier today. So that way you'll have them and look at your leisure. So the final exam will be 150 points. 100 points will be on skeletal muscle mechanics from active tension and factors there all the way through today's lecture on arthritis. I think that's chapters 16 through 20. I think that's right. So muscle, tendon, ligament, muscle, bone, tendon, ligament, cartilage. Yeah, 16 through 20. There will be 50 points. It'll be cumulative, but I'm going to focus a lot on skeletal muscle mechanics since that was covered on test 2 and test 3. There'll also be some basic material related to mechanotransduction, pressure, Newton's laws, torque, kinematics, and there'll be some skeletal muscle um, um, anatomy, basically function for the most part, what muscles contribute to what type of movement, planes of motion, etc. So I think you probably know at this point what to probably expect from the exam. And again, good luck to everybody. Congratulations in advance to everybody who's graduating, virtually graduating. I wonder if there's a way to see the virtual graduation online. That'll be interesting. Um, so again, best of luck, and hope that everybody will be able to get out of their homes soon. We're state of Texas is starting to open up again, and I think that will hopefully continue through the fall. We'll keep our fingers crossed, and maybe we'll all reach herd immunity before the first football game. Have a good one, and we will talk to you soon.